Firstly, greetings to every virtual one of you. I'm so sorry I cannot be with you tonight. And then my thanks to Lendelwa and SkinCeuticals for the privilege of sharing some thoughts in defense of a universal topic so impactful on African ground. If you think about it, encountering our African painted wolves in nature invariably enhances our quality of life. But on the contrary, having to bear similar markings on our own face does exactly the opposite. Dyspigmentation is a high impact game with major repercussions for quality of life, and yet potentially also high gains. And this means that in-depth knowledge is crucial not only to our understanding of this pervasive process, but for designing and selecting effective therapy. So for tonight, I thought we'd look at 7 steps and 7 actives integral to insightful management. So to start at ground level. Melanocytes are highly specialized dendritic cells which transfer melanin to keratinocytes in subcellular melanosomes. And recently, the epidermal melanin unit has been expanded to include the Langerhans cell, making regulation even more complex. And mechanisms include environmental, genetic, and endocrine factors, in addition to a crucial signaling pathway called WNT, or the wingless integrated pathway. There are several steps involved in melanin production, knowledge of which helps us to accurately position our treatment. And as often, it all starts with the sun, which causes irritation and the formation of free radicals, which then activate transcription and production of the tyrosinase gene, which after activation activates production of melanin with subsequent dispersal to adjacent keratinocytes. All these steps may be targeted in specific ways. Formation of free radicals may be countered by the use of antioxidants, vitamin C, vitamin E, and arbutin. Inflammation may be countered, other than by steroids, with glycyrrhetinic acid and also arbutin. And this entire step may be suppressed by the retinoids, especially prescription retinoids, also over the counters. Glycosylation of the enzyme may be suppressed, but one of the main targets is inhibition of tyrosinase. And this is where actives such as hydroquinone, arbutin, ascorbic acid, glabridin, kojic acid, and resorcinol work. Ellagic acid works by binding to the copper at tyrosinase's active site. And then dispersal of melanosomes may be influenced by using niacinamide, protease inhibitors, liquertin, and also retinoids. And throughout, melanocytes are under constant regulation from both epidermal and dermal cells. Both fibroblasts and keratinocytes secrete paracrine factors. Sebocytes are now thought to influence the distribution of facial lesions. Increased vascularity causes endothelin-1 production, which acts as a potent activator. Mast cells play a role, and obviously, damage to the basal membrane zone allows melanin and melanosomes to drop into the dermis. All these processes are tightly controlled by special signaling pathways, which may initially seem confusing, but this is exactly where the research is happening. And they all have MITF, or microphthalmia-inducing transcription factor, as their primary target. The main pathway involves the melanocortin receptor and is activated by alpha MSH and also ACTH. A second UV-induced pathway involves protein kinase C. And then a fibroblast-stimulated paracrine stem cell factor pathway becomes involved. UVB triggers the endothelin receptors in vessels. Think of us going red in the sun and then brown. Paracrine pathways stimulate the histamine receptors and explain histamine-induced melanogenesis. Think of papular urticaria. And then there's post-inflammatory hyperpigmentation, ubiquitous and operating via multiple paracrine factors. A critical path, though, is this WNT or wingless integrated path because it induces not only melanogenesis, but dendritogenesis and also proliferation of melanocytes. And interestingly, it operates independently of ultraviolet. Signaling leads to gene expression and then to transcription of pigment. And this pathway is controlled by 3 repressor genes, which have been named by scientists with a sense of humor because they are called frizzled, disheveled, and groucho. And these factors can be either switched off or switched on. And this pathway has been proven to be inhibited by the DICOP1 agonists, which are, amongst others, active during embryogenesis, and the reason that the skin on our palms is paler than the skin on our dorsal hands. And so we can see the playing field in the pigment game is vast, but fortunately, it also includes numerous scientifically proven therapeutic options. And now I would like to address 7 actives. And the first active we need is actually ourselves, because we need a plan. And one of my reasons for featuring the African wild dog is because they're known to be incredibly efficient, planned hunters. And we too need to be informed, to have a system, and also a questioning mind. Now, the one step we never question is adequate sun protection against the entire UV spectrum and also visible light. But thereafter, we never stop questioning. Firstly, is there active inflammation? If so, is there a cause? If it is acne, there are agents to treat both cause and consequence. If it's not acne, we need to treat the inflammatory cause and practice sun protection. If there's no active inflammation, the question is whether the patient can tolerate first-line hydroquinone therapy. If not, we need to know the alternatives. If the patient may use it, depending on body site, we determine the formulation according to site. In patients who are resistant, we may consider using energy-based devices, taking patient costs into account for this long-standing condition. But our patients instinctually know what has been proven in science, that improving homogeneity of skin tone can reduce perceived age by 15 to 20 years. Our patients are informed, sometimes desperate. And this is a patient who was resistant to hydroquinone who showed great benefit from a single non-ablative thulium Fraxel. Then we need to make active use of evidence-based medicine. There truly has been an exponential increase in consumer awareness around their general skin health, but also aesthetic needs. Our patients are reading, and we should be too, but evidence-based science. And in addition to quality of life, quality of evidence is important, and our number one treatment remains triple therapy as we've learned to know it. A recent systematic review reiterates that no single treatment is universally efficacious, and combination therapies, either double or triple, still yield the best results. There are promising systemic options, such as tranexamic acid and polypodium leukotomas. Microneedling and peeling, although efficacious, have not been proven superior to hydroquinone. Lasers and light devices may be effective, but patients need to realize that they do not preclude recurrences. Then our prescription actives, which remain the gold standard. Hydroquinone has a complex mechanism of action and is a competitive tyrosinase inhibitor. We do know that side effects such as irritancy need to be managed and that sun protection is mandatory. Despite the fact that it's cytotoxic, no carcinogenicity or systemic absorption has currently proved to be a problem. What has been a problem in our country is ochronosis, probably due to high concentrations, prolonged use, sun exposure, and the possible additional use of resorcinol. Prescription retinoids also have a multimodal action and form part of our first-line therapy. They are also additionally valuable in enhancing penetration of other agents and also in treating concomitant actinic damage. Meconol and also azelaic acid are other tyrosinase inhibitors, and azelaic acid is useful in pregnancy and also because it is known to lighten only the hyperpigmented skin. An exciting, more recent addition is tranexamic acid, which is being used both systemically and topically. And where this denotes the usual melanin pathway, melanogenesis may also be induced via a plasminogen pathway, which in itself activates two other mechanisms of pigmentation. Tranexamic acid works at this lysine binding site, blocking both these subsequent mechanisms. A fourth active is our own active understanding of the place of cosmeceuticals. And here, truly, the literature has been exploding over the past 10 years. Look at the increase in peer-reviewed publications regarding just nanotechnology for pigmentation. Importantly, we always need to understand where each proposed topical works. Sun protection is vital. We can use free radical inhibitors, tyrosinase inhibitors, and affect melanosome transfer and keratinocyte function. Just to mention a few of the cosmeceuticals, the licorice root extracts are known to be useful for pigmentary purposes because they act as free radical scavengers, they act as anti-inflammatories, they are tyrosinase inhibitors, they help to disperse melanin, and also the breakdown of melanin. In addition, they help for sun damage because they've been proven to reduce breakdown of elastin. Nicotinamide or niacinamide is anti-inflammatory, moisturizing, and also, as we saw on our scheme, reduces transfer of melanosomes. And then allantoin, other than being used for tissue scaffolding, it has anti-inflammatory properties and also aids exfoliation because it physically affects the desmosomal bindings. Blue daisy flower extract, or L-arbutin, is a tyrosinase inhibitor and also a hydroquinone derivative with low toxicity. And interestingly, it has been shown to stimulate the beneficial NRF2 pathway, as does resveratrol. And the one thing we should never forget is that our patients need active support throughout all 4 seasons of the years. And often there are seasons of treatment and seasons of less active treatment, but we need to support them through them all and remember to make treatments cost effective. Sun protection throughout is mandatory. And preparations with iron oxide have been proven to be helpful against the use of visible light. And as for future research, the future promises many new therapies, most of them focusing on multiple causes, such as histamine synthesis, estrogen regulation, the transfer of melanosomes, and free radical generation. And due to their favorable safety profile, natural agents with a multimodal mode of action are being very actively investigated. These include resveratrol and coumaric acid, which are antioxidants, liquertin and niacinamide, which inhibit melanosome transfer, and antihistamines and zinc. Thus, to conclude, importantly, melasma should no longer be seen as just a simple abnormality of melanocytes because it's far more complex and has the clear hallmarks of a photoaging disease. We are hugely fortunate in having an extensive array of topicals at our disposal. And when facing a condition with such a huge impact on quality of life, it behooves us to fully understand all the options. We have the mechanisms. We have a growing armamentarium of treatment. And so, even though melasma remains inherently incurable, it is supremely treatable, especially if we adhere to evidence-based medicine. And I truly believe that if we do this, we can look the future and our patients straight in the eye. And with this, I thank you.